So we start the meeting. Dr. Biyani, you can switch on the video now. Yes. So good morning and welcome back to Saturday Club morning meeting. Today we have a very eminent speaker, Dr. Naresh Biyani. He's a consultant pediatric neurosurgeon from Mumbai. He has done his MS and DNB in general surgery and MCH and DNB in neurosurgery. He did his fellowship in pediatric neurosurgery at Tel Aviv, Israel, and Great Ormond Street Hospital, London. His areas of interest are hydrocephalus, spinal dysraphism, and tethered cord syndrome, cranial dysraphism, pediatric neuro-oncology, epilepsy surgery, microneurosurgery.
You are not audible.
Oh, sorry. Am I not audible?
You are audible, Sateshwar.
Okay. He is affiliated to many reputed hospitals in Mumbai, like Bombay Hospital, Bhatia Hospital, Fortis Hospital, BJ Wadia Children Hospital, Hiranandani Hospital, Jupiter Hospital, and other hospitals. Apart from this formal introduction, Dr. Naresh Biyani is very, very active. He is known amongst academic circle as one and only pediatric neurosurgeon that I at least know about in India. So it's a pleasure to have you, Dr. Biyani, with us on this Saturday Club morning meeting.
Good morning, sir.
He is going to talk about the role of prophylactic surgery in tethered cord syndrome. So over to you, Dr. Naresh. You have about 40-45 minutes to talk, and we'll keep about 10 minutes of discussion. So over to you, Dr.
Remote
Sorry for this. Okay. I muted the participant.
Yes, sir. Is my skin visible, sir?
Yes, very well.
Okay. So today what I'm going to discuss is the role of prophylactic surgery in tethered cord syndrome. Okay, in next 30 minutes, what is the role and what is the spectrum, how the pediatrician or a clinician can diagnose spinal dysraphism or tethered cord syndrome. Okay, so I'll start with first case. This is a 6-year-old child who had a swelling in the back. No imaging was done, and he was operated at the age of 3 months. Now at 6 years, he comes with the neurogenic bladder and clawing of toes. Okay, so we have a scar where the subcutaneous lipoma was excised. And the MRI that we did, the spinal cord is lying low and is attached with the lipoma. Okay, so there is another girl, Sanvi Patil. She comes at 3 months with again the swelling in the back, abnormal gluteal cleft, and again she has this same type of feature, low-lying conus and the lipoma. Now the question is that what is it? Number one. Number two, why God has given that lipoma, the external marker. And number three is that can we alter the natural history of the disease? Untreated, this child would also land up with neurogenic bladder and bowel. Now this child was not born with neurogenic bladder and bowel, and they land up. So that's an acquired deficit. Okay. So in an era of X-rays, what people would do with simple X-ray, and they would find a spina bifida, the bifid spinous process. And then they labeled it as spina bifida. And this is a layman's word, not to be used in the medical literature. The better word is spinal dysraphism. That means that there was some embryological abnormality during the development of the spinal cord. And still the better word is to use is tethered cord syndrome, because it denotes the physiology and the tethering element, the anchorage and the damage that can happen due to the low-lying conus, and gives the more weightage to the symptomatology. Okay, how do the clinical spectrum present? So this is an open neural tube defect where we can see the spinal cord, unhealthy skin, and then the pouch. And most of these children are having lower limb weakness and CTEV also. 30% of them, they develop hydrocephalus also. So this is an extreme end of open neural tube defect in spinal dysraphism. But with better antenatal sonography, our incidence of seeing this has been decreasing. Now, what we see more common is like this. This is a parchment type of skin, okay, and absolutely normal neurology. You can have patch of hair. or a swelling in the back with the cutaneous tract, mild swelling. This is a cystic swelling, and this child almost had infection also, presented with sepsis. You can have a human tail or a cutaneous remnant. Abnormal lipoma, that are not in the midline, they are paramedian. Strawberry nevus. Now another cystic swelling, just at the cervicodorsal region. This got ulcerated because of the position. And these children have no neurological deficit. Dermal sinus, that is 2 centimeters away from the anal cutaneous margin and is outside the natal cleft, If we have to really open the gluteal cleft and see, then it is not serious. But anything outside the natal cleft is pathological. Patch of hairs. These are the neonates. And this is a grown-up lady. You see this? This is a 8-year-old, 9-year-old children with patch of hairs. Then we can have strangle shoulder or a scoliosis. Okay. So and sometimes, we see the neuro-orthopedic deformity without any lumbosacral cutaneous stigmata. So next time when we see all these things, they denote that there can be an element of spina bifida or spinal dystrophism or tethered cord. And basically what we would see is this is a vertebral body, this is a spinal cord, and you can have a meningocele or a meningomyelocele. Okay. So why we are interested in learning this, because these children can be safely treated if diagnosed appropriately. Suppose I see a neonate, what would be the best time to investigate? Usually we do a MRI study at around 4 to 5 months. Okay. Suppose we see a child less than 1 year, we just have to get a specialist opinion and reassuring to the family. I'm not going to operate before 6 months, since the child will be in the recombinant position and the tethering element doesn't cause adverse effect. After 6 months, the child is able to undergo the surgery and anesthesia safely. So if the skin is healthy, there is no rush to get an MRI in a neonatal phase. What I see quite frequent is that day 3, day 4, they get an MRI done. And we are not going to do any surgery at that moment of time, number one. Number two, when we do a surgery at 6 months, we might have to repeat the investigation. And getting a neonatal MRI is potentially dangerous to the neonate as well, because of hypothermia and anesthesia. So we like to avoid that. Abroad, what they do is a USG, ultrasound. But again, it is an operator-dependent investigation, and it requires a very high resolution ultrasound that is not available everywhere. Okay. Now, the biggest problem is that suppose the USG shows something, still no surgery would be done without getting a confirmatory neuroimaging MRI. So this is just a diagnostic or a what we would say is a sensitive tool, but is not of use. So I don't use it in my clinical practice. CT scan, again, pediatric surgeons are very fond of getting a scan done, CT scan done, but it doesn't tell you about the intradural pathology. And again, CT scan is ionizing radiation, so we don't want to expose our children to the radiation. Okay. Urodynamic study is also important, but less than 3 years, the child is not cooperative, and it's very difficult to get a urodynamic study done. And again, it is not available at all the places, So the best thing that we can do is USG kidney and urinary bladder, and the most sensitive tool, that is post-void residue. So the post-void residue is more than 5 ml, then there is a element of neurogenic bladder, and that needs to be further investigated. Okay. Now the crux of this talk is this slide, what is the role of prophylactic surgery? There are very few diseases where we do a prophylactic surgery. So when we do a prophylactic surgery, we have to satisfy 3 criteria. One is that the prophylactic surgery, we should know the natural history of the disease. And in tethered cord, we know that unless treated otherwise, all of them would develop neurogenic bladder, and few would develop a neuro-orthopedic deformity also, and sometimes, neuropathic ulcers as well. Okay, so this is just a matter of time. In all the children that we saw with the neurocutaneous stigmata, this is just matter of time. Second criteria is that by doing a surgery, can we alter the natural history of the disease? And again, we have a vast experience that shows that appropriate surgery done at appropriate time, they don't develop any further deficit. Okay. And the third criteria is that the risk of the operation should be negligible. It cannot be more than 1 or 2%. If it is more than 2%, then it is not fair for the child as well, So with better technology, experience, microscope, intra-op monitoring, the risk is becoming more and more negligible. Okay. So what are the risk factors? Why are we so much worried about it? See, what happens is that normally the spinal cord and the sacrum are at S2 level. And when the child is still in the womb, the vertebral body increases more compared to the spinal cord, and slowly the spinal cord ascends up. At birth, it is like L3, L4. And then during 9 months, it becomes L2, 3. And in adult, it becomes L1, L2 junction. Okay. But if some element is catching the spinal cord down, the vertebral bodies are going to grow. And that is where the stretch starts on the spinal cord. There's a limit where the spinal cord can take damage. And after a certain time, there is an irreparable damage or irreversible damage that happens at the mitochondria level of the spinal cord. Okay, so we need to release the spinal cord before these things happen, irreversible damage happens. Okay, so when is that happens? When the child starts sitting upright posture, that is after 6 months, with support, without support. And any truncal activity, the flexion, extension of the trunk would cause stress on the spinal cord, and that causes micro movements and micro damage on the spinal cord. Another is that 5 to 6 years, the first growth spurt that happens in the child. And another is the pre-pubertal growth spurt, where the child will see, at 9 years, 10 years, everything was normal. And then suddenly the child develops a neurological deficit, neurogenic bladder, repeated UTI, and that is quite missed. Okay. The most dangerous part of the spinal cord is the S2, S3, S4 segment of the spinal cord that supplies the parasympathetic innervation to bladder and bowel, and they take the brunt of the injury. And we need to intervene before irreparable damage or irreversible damage is done. Once the damage is done, no matter what surgery we do, it doesn't recover back. Okay, so this second slide, if we can understand this, the crux of the talk is done. Okay, so we'll share some examples. So now we see a child that is 4 months old. You see there's a strawberry nevus and small patch of hair, There is nothing, no neurological deficit. And when we see the MRI, the spinal cord is lying low. Normally, the spinal cord should end up at L2, L3 level at that age. But here it is all locked down. And then there is a syringomyelia also, that is again after effects of a tethered cord. Okay. And on a T1 weighted images, we can see a bright fat, the phylum is fatty. Okay. Incidentally, the child also had diastematomyelia, but this need not be treated. Okay. So what I do is that so while releasing the fatty phylum, we applied 2 Liga clips and then they release the cord, and a simple X-ray would show the suppression of the Liga clips, So that would be the radiological evidence, these 2 Liga clips were applied next to each other. And in 6 months time, you see that this much the spinal cord has ascended up. And that much was the tension in the spinal cord. Another case, the 18-month-old child comes with backache, severe backache and tenderness in the back. Okay, and was having fever, On close examination, they could find a sinus. Okay, but they couldn't conclude, that this is related to his backache and all those. So we got an MRI done. An MRI showed that there was a dermal sinus, and then there was an epidural abscess, and then intradural also epidermoid. Okay, so a simple looking sinus can have big complication also. Okay, during surgery. This is the dermal sinus with the tract, and we can see the defect in the lamina. Okay, now the laminotomy is being done, and we can see the sinus tract, that is continuous up to the dura. Okay, and then when we open the dura, the dermoid is all going in, So, and this is the upper limit of the attachment of the spinal cord. These are the cauda equina nerve roots. And luckily, this child, the infection had not got into the intradural cavity, and we could excise it totally. Okay, so a simple looking sinus can be very dangerous as well. So this was the extradural component of the dermoid with infection, and from here on, these are all intradural dermoid. Untreated, this would keep on increasing and naturally get infected, number one, or can cause chemical meningitis as well. Okay, another child, you see, there's a secret butt appearance in the thorax and came with weakness in both lower lip, left side more than the right side. And on imaging, you see this is the intramedullary dermoid, and then there is a tract, and then there is a sinus. Okay, the spinal cord is squashed on the opposite side, and we can see whole of the thing is dermoid. So this is a diffusion weighted images that we see, and we can easily see the dermoid and is trying to come out. The spinal cord thickness is like this, and 1/3 and 1/3 CSF space we should be seeing. Here the spinal cord is all squashed. So surgery, elliptical incision. So this is the part at the lamina, and now it is going and attached to the dermoid, intradural. So here, since it is an intramedullary, we cannot take out the dermoid in toto. So what we would do is that we'll open the capsule and debulk the pultaceous material. And this is at the end of the surgery, where we can see the severe spinal cord compression, and then everything is been excised in toto. Okay, and we can see, there are hairs as well, So now with the better technology, we see the cases being diagnosed antenatally as well. So this is a 28-week gestation. Ultrasound shows meningomyelocele, but there was no carry herniation, and then there was no ventricular dilatation. Okay, you see this here? There's a bulge in the back, and this is the vertebral column. Okay, and the spinal cord is coming out, and then there is no carry herniation. So when the child was delivered, this is what we had. So this was a lipomeningomyelocele, and there is no rush of surgery, surgical treatment immediately. Okay, at 6 months, we can do the surgery. This is the MRI that we got in the. So this is the spinal cord. This is a posterior neural tube defect where the spinal cord is attached to the subcutaneous lipoma, and there is a syringomyelia as well. So during the surgery, we have to repair we do the detethering and put back the spinal cord in the canal, and also have to repair the muscle and the posterior layers. This is another one, 28-week gestation. Antenatal ultrasound shows that there was a abnormal echogenic foci at the lower dorsal region. Okay, the vertebral column was normal. And when they got it done at the axial cuts, they could see the bony spur and 2 spinal cords. And then above and below were the single cord. Okay. So the child is delivered. In fact, this child is from Baroda actually, sir. This child is from Baroda actually. This was long back when, this 2009 actually.
Oh.
That was shared to me by Dr. Hiren Doshi, who is a radiologist over there.
Mm-hmm.
So this is the dermal sinus. Okay, there is no patch of hair, nothing, So at 3 months, we got an MRI done. So MRI shows that there is a bony spur. The spinal cord is tethered at L1, L2 level, and also low-lying conus. There are 2 spinal cord, and the bony spur splitting the spinal cord. Okay, so this is the bony spur that is better seen on a CT scan. So the surgery is 3 surgery. One is this surgery to get the bony spur out, the low-lying conus, and also the dermal sinus that needs to be excised. Okay, this is a infertility treatment done after 12 years. The child conceived after the marriage, and antenatal scan showed there was a meningomyelocele. Okay, this was at 19 weeks, and the family was very much concerned, and they wanted to make sure, if the child has a good prognosis to continue the pregnancy. That is when I got involved. We got a fetal MRI done. The fetal MRI showed that there was a cystic swelling in the back, low lumbar sacral back, but there were diastematomylia. Okay, meningomyelocele is the defect in the primary nervulation, and diastematomylia is the defect in the gastrulation. So rarely they go combined. And when we got a neuroimaging done, and these are all fetal MRI, so there was no hydrocephalus, and then there was no carry herniation. So primary nervulation tube defect were ruled out. The pregnancy was continued, and this is what the child was born with. Okay, this was a local meningocele that was repaired on day 3. And then when the child was 4 months old, we got this is a scar at 4 months, and then we got an MRI done that showed that there was a syrinx in one of the hemichord. There was no bony spur, and then there was a low-lying conus. Okay, 2 spinal cord, and the left hemichord was attached to that element. So if I release this and release the low-lying conus, the child has a normal outcome. Okay, last case. This is a 4-month-old child that has a meningocele type of swelling defect that is cystic. When the child cries, it increases in size. Okay, so we got an MRI done. The MRI showed that there is a low-lying conus, and then there is a band of tissue that goes and anchors over to the dome of the sac, and the defect is very, very small. So that was not picked up on the scan as well. But in the lateral scan, we could see that. And then there is a fatty phylum that ends and causes the low line. So here the tethering element is the low line conus and also the band. And as the baby cries, the sac increases in size, and that causes an additional tuck to the spinal cord. During the surgery, okay, now we are dissecting the meningocele sac. And these are the tissue, these are non-nervous tissue that are attached to the dome of the sac, and on the anteriorly, they get attached to the spinal cord. Okay, you see this here. So this is what the surgery was there. Okay, so we released the band near the spinal cord, and also the fatty phylum was detethered. Okay, now there is a very nice entity is known as limited dorsal myeloschisis that was described by my mentor from San Francisco, Dachling Pang. Okay, so this is, everybody would label this as meningocele or meningomyelocele. Okay, but this is not both of them. Okay, another one. Normally they are at lumbosacral region. And this is a classic picture, you have a parchment type of a skin, and then an unhealthy skin, and then the normal skin. Okay, you see this is a pathognomonic of a limited dorsal myeloschisis. Okay, so Dachling Pang in 93, he described this as cervical meningomyelocele, and in 2000 he again relabeled this as limited dorsal myeloschisis, where there is a defect in the disc junction, incomplete fusion. Okay, and what happens is that's a neurofibrous tract that remains, and that is attached to the spinal cord and cause the tethering of the spinal cord. Now there are 2 varieties. One is a cystic variety, and then this is a cystic variety, and then you have a sessile variety. Okay, so you see this child now. This is the 8-month-old child with the swelling in the back. Okay, arising from the cervical region. So when we do an MRI, there is a defect over here, and there is a band of tissue that is anchored and gets anchored at the dome of the sac. It doesn't have a neurogenic element. What we just need to do is to disconnect the band at this level, and then repair the posterior spinal elements and excise the excess skin. Okay, now this is a sessile variety of LDM, where we see just a cutaneous tag. Okay, the child has a sprangled shoulder, short webbed neck, and you see the spinal cord. Here we can see a small fiber, the element that is attached over here, and there is a big posterior spinal dysraphism. Okay, so this band is attached to the dome, and all that is needed is just release this band. Okay, so LDM, the limited dorsal myelocele is different from meningomyelocele because this happens at gastrulation, and the other defects happens at primary nervulation. They don't have a neurological deficit to start with, and tethering element is just a band of non-nervous fibrous tissue and has a very good prognosis. Okay, take home messages. As a pediatrician, everybody should look for the neurocutaneous marker. And if there is a neurocutaneous marker, MRI remains the investigation of choice. We operate them prophylactically. Good outcome in filar lipoma, dermal sinus, split cord malformation, spinal cord lipoma, Also, it's complicated, but at trained hands, it is safe and early surgery is recommended. Operating microscope is very, very essential. And now we have a multidisciplinary spina bifida clinic where these children with orthopedic deformity, the occupational therapy, neurogenic bladder, the pediatric urologist. So the child doesn't have to run pillar and post for each consultation. They get all the consultation done at a single room. SRCC hospital. We have been running spina bifida clinic for almost more than 5 years now and has got a very good response. Okay, so good outcome if treated appropriately. What happens is that most of the people, because of their past experience, they have seen that no matter what surgery is done, they don't recover. Or some of time they have seen the disaster, the child was walking and then after surgery they became paraplegic and they are worried, for recommending a prophylactic surgery. And another thing is that not all spina bifida is meningomyelocele. Now, in my practice, maybe meningomyelocele is less than 5% of tethered cords that I operate. 90% of 95% of them are closed neural tube defect without neurological deficit and treated appropriately has a very good outcome. So apples are apples, oranges are oranges. Thank you for attention.
Thank you, Dr. Biani. That was excellent with so many illustrative cases that you elaborated upon. You can stop the screen sharing. Yes. I think the message is very clear, but how are the parents' reaction to this prophylactic surgery? I mean, how difficult or easy it is to convince them to go for this kind of surgery?
So when we meet first, we have to tell them, give them the appropriate information. And if we talk logically, they understand that and they accept it. For me, when I started my practice, the most difficult part was to convince the pediatrician actually, because they were not still very happy about that. The same thing happens with craniosynostosis also. They haven't heard, they haven't discussed, so they are more skeptical. So once the pediatrician is taken into confidence, and again the family are very open to the discussion, like they are neutral party. They have not seen good, they have not seen worse, so whatever is been guided appropriately, they would follow that actually. And
Yes.
with internet and all those stuff, our convincing becomes less forceful now, because they would have gone on the net and they would have seen something, the deficit part and all those stuff. So that has made our life relatively simpler in past 5 days. When I started in 2009, it was damn difficult, to even what about family, even the pediatric neurologist, they see a handful of cases and they would be very skeptical about the prophylactic surgery. And because of their past experience, the more worrisome thing was that any neurologic surgery leading to a neurological deficit is a guilt, take it on the heart that it's the deficit has happened because I referred to a neurosurgeon. But with appropriate technology and all those stuff, so things have become very safe. And fortunately, I have done more than 2,000 such cases. So naturally, pediatrician, whoever has seen my work or heard about it, they refer us.
Right. So every child with external sign of dystrophism should be subjected to MRI at least. That is the dictum I think we should all learn.
We are lucky that we are living in this era of MRI. I would be like feeling very upset that the same thing was like 20 years back or 25 years back or 30 years back, where there was just X-ray as a tool. And for a clinician, even for a neurosurgeon, they would not know anything, like we have to open up, see things, and then take a decision. So MRI has been a big blessing for our generation, actually.
Very true. We have Jagdish Bhai as a surgeon with us. Give any comments?
Excellent work, Dr. Biani. We are very happy to see so many cases. I don't think we get so many MRIs done up at KGP, where we have spina bifida cases being operated. But I think we would be referring more cases for MRI now, having seen this.
In fact, parents are
Certainly.
often worried about those dimples and all that, and they
Yeah.
do. Okay, sir, iska kuch karna chahiye nahi. Most of the pediatrician would
Yeah.
say, no, it's okay.
Getting MRI done at age of 6 months or less than that also is a bit difficult to convince also.
No, if we, sir, what has happened is that if we tell the family appropriately, like this PDF thing, I have kept it in a PDF and I give them the family, like these are the neurocutaneous markers, and MRI would be helpful to know that. So the family is, the family is not worried about the MRI or the cost of MRI, but they just want an appropriate care. And
Yeah.
adequate information, if they is handed over to them, they take, in fact, they are very keen, when I tell them, when I see a child at 1 month and tell them, to get an MRI at 5 months, they say, no, we don't want to wait till 5 months. We'll do an MRI now. I have to convince them, please do it now, because if I have to do a surgery at 6 months, again I have to repeat it, They बोलते हैं, हमारे को 5 महीने तक का भी tension नहीं चाहिए. Means it's the other way around,
Yeah, I agree that today's parents are very much aware, and they would read a lot and they would know also more. So that acceptance is easier now than earlier days. Very true.
And sometimes, there is a force,
The advice to wait.
I speak to Satish sir and I tell him, that there is no need of MRI. The family goes to another pediatrician. अरे अभी तक MRI नहीं किया, अभी का भी MRI करना है. Like these are the things that we see nuances in our practice. But I think if we give them appropriate information, why we are delaying the MRI and what is the benefit that we are getting it, so the family, they take it very positively.
Very true. I think that awareness building is very important. And I think you have been talking about this subject for the last decade now, actually. I heard the same talk. I think you visited Baroda once and you
That
had
was long back, sir, actually.
long back, yes.
2012.
Yeah.
Things
So-
have not changed, sir. The diseases are the same, It is just the awareness that is needed among the
Yes.
pediatricians, sir.
Yes, very true, very true. And this video will be, is there on the YouTube. So many of my, this followers of the Saturday Club, they don't find this time 8 a.m. On a Saturday morning appropriate, but they see all these talks later on. So this message should go to many parts of the country.
Yeah,
So
it's my
thank you.
pleasure.
Yeah, thank you very much, Dr. Naresh Biyani, for taking time out from your very, very busy schedule. And we look forward to some more talks in the future also.
Yes, sir. Anytime, kenosinosis is a
Yes.
neuro-oncology, pediatric neuro-oncology. Those are my big area of interest.
I think these are also very important topics and often neglected, especially craniosynostosis, as you said, no? So we would like to know more about that also. So in future. So thank you, Dr. Biyani, for joining us, and thank you all for participating in this morning meeting. So we meet next Saturday morning again. Thank you and goodbye. Thank you.